We are going to start it with Professor Wedzicha from UK, because she's online with us and her presentation is recorded as well. So she's going to start with talk about implementations of biomarkers to improve prognosis of COPD. Then we'll come back to Dr. Ashraf presentations. So Professor Wedzicha from UK, she's online with us now.
Hello, can you hear me, everybody?
Okay.
Hello, can you hear me? Hello, can you hear me?
Yes, we hear you.
Oh, lovely.
Yeah.
So thank you all very
Go
much.
Ahead, welcome.
Yes, I'm off. Thank you very much, and thank you very much for the invitation. I'm here. I've battled the technology on a Saturday morning. I'm going to talk about biomarkers, my conflicts all only this year, because I used to edit the journal. I'm going to start off with acute exacerbations, and this is interesting. Can we use biomarkers to help us manage acute exacerbations? At the moment, it's steroids and antibiotics, and I must say I am still rather old-fashioned here, and I think I would use symptomatic criteria. But this was the first study that was done using eosinophils cutoff plus 2%. You get antibiotics, minus less than 2%, you don't. And basically, in the two groups, the standard arm and the biomarker arm, the outcomes, as you can see, CRQ, lung function, and visual analog score were very similar. It was a small study, the first one. There's been more interest in to guide antibiotic prescribing in COPD exacerbations. So this was a study a few years ago in New England. Usual care you see in blue, CRP guided group in red. And as expected, there were less courses of antibiotics that were used. However, the problem with CRP, if you're using it in primary care, you need a system. A lot of patients now self-manage for COPD exacerbation. So my own view is if the CRP is high, above 30, you will have a bacterial infection. The problem is, I still think that increased sputum volume, sputum purulence is the best biomarker, whether or not you need it. And I think this is shown by this meta-analysis. This is interesting. On the left is a meta-analysis of studies that use CRP to detect bacterial infection on the left. On the right is procalcitonin, PCT. Basically, the evidence is, but it's not particularly great. Basically, you can see the CRP comes out at about 20 to 30. The procalcitonin is much nearer the center. In fact, procalcitonin doesn't seem to be as good as CRP in telling you whether or not you need antibiotics. But my own view is I don't think the data is good enough. The CRP can go up as procalcitonin in other infections. But what about using CRP differently? And this is a time course of exacerbation from our data. And the issue is that exacerbations don't get back to normal. And we know we get repeat exacerbations. And at 35 days, about a quarter of the exacerbations haven't returned to normal. Some years ago, we did the study. We followed exacerbations with CRP and other biomarkers very carefully. In fact, CRP was the best out of all the biomarkers we looked at. If the exacerbation doesn't recover, around 10 to 14 days, there's an inflection point, and the CRP started to rise again. If the exacerbation recovers in the dotted line, the CRP falls. So in that case, we went on and got a grant to do a randomized controlled trial of retreatment of incompletely recovered exacerbations. So this was a very difficult study to do because we had to screen a lot of exacerbations to get those that did not recover. The power was 144, 72 in each group. And basically, if at 14 days, either the symptoms increased or the CRP was above 8, the patients were given another course of antibiotics. And it didn't make any difference. We used ciprofloxacin as a second-line antibiotic. Interestingly, if we only use CRP as the criteria, then the data was slightly better. So I think this needs repeating. It does suggest that incompletely recovered exacerbations may well need more anti-inflammatory treatment than antibiotics. So I think there's a lot of work to be done. There's another interesting rise in exacerbations in biomarkers, which is troponin. And this is a study we now did almost 10 years ago, where we again followed exacerbations, but we divided patients into whether they had ischemic heart disease or no ischemic heart disease. If you had ischemic heart disease, your starting off troponin was higher, and it basically maintained higher over the 5 weeks we followed the patients, while if you didn't have ischemic heart disease, the troponin was low and didn't go up so much. And the same indeed for BNP at the bottom. So although we don't follow, it does explain maybe why there is an increased cardiovascular risk around exacerbations. Talking about biomarkers and cardiovascular risk, this comes from the SUMMIT study, where you will remember a large number of patients with cardiovascular risk were given lab ICS. The study was negative, but this is interesting. The purple lines are the highest quintiles of troponin, and it's these patients who are most likely to have composite markers. The troponin was taken at baseline, and on the right, probability of cardiovascular death. However, it does not tell you whether or not you'll get a COPD exacerbation. I think that is right. So actually in COPD, an elevated troponin marker of eventual cardiovascular death. I'm going to talk now about chronic bronchitis or chronic mucus hypersecretion as a predictor of frequent exacerbations, and also as an early biomarker for patients. And I think this is important because it will link with CT scanning. Many years ago, we showed the number of exacerbations in the previous year, predicted exacerbations, and also bronchitis and also SGRQ. And this was the data from ECLIPSE. You'll remember this, that 40% of patients had at least one, 22% in stage 2. And basically, over the next 3 years, ECLIPSE was a 3-year follow-up study, the exacerbations ran true. So you could predict exacerbations from 1 year to the next. Again, this is Spiromics, who tried very hard to find a biomarker, and again showed acute exacerbations in the year before baseline here were good productive. The CAT, we also found that, but not as good as the exacerbation frequency in the year before baseline. But the first time they showed, again, a weak relationship with CT changes. This is parametric response mapping on small airways disease, inspiratory and expiratory scans. Indeed, none of the biomarkers were very good. And another paper was written on biomarkers combining spiromics and COPD gene. And basically, there isn't a biomarker at the moment that can predict exacerbation frequency. Well, this is the parametric response mapping, inspiratory, expiratory, and you get the small airways disease, which is in yellow. And you can see that small airways disease is early in GOLD 1, and then emphysema is later, unless of the phenotype who get early emphysema and alpha-1 antitrypsin. Now, this is important. I think that CT parameters, they're still being enhanced. You can see mucus on these scans if you look closely enough. I think this will be a very important biomarker of early disease, but it still needs working out. And we've currently got 500 scans in 30 to 45-year-old smokers, and already at least half of them are abnormal. So why am I so interested in bronchitis? This is data from the 1946 UK birth cohort. And this was a cohort set up to monitor the introduction of the UK Health Service. The dates here show you the dates, 1982 to 1989. The patients were aged 36 to 43. And this seems to be the watershed moment. The red are the continual smokers, increased prevalence of bronchitis, and it goes up. If you stop smoking in green, the bronchitis reduces, and blue doesn't at all. And what James Allinson also showed in this study is that the you need 10 pack years minimum to start getting problems. So there is a window also to stop smoking cigarettes. We know from the Framingham study, for instance, that if you stop smoking before 40, you don't do so much lung damage. So this is all consistent with this very important early phase. He then looked at the odds ratios when they were 36 and 43 in developing airflow limitation by the age of 60 and 64, and you can say these are highly significant. Furthermore, bronchitis is intermittent. It tends not to be continuous in a lot of people. So this was a number of occasions that patients reported bronchitis between 43 and 64. And what you can see on the left, the lung function decline is much faster the more bronchitis you have. And this is very different from what Fletcher and Pito told us, because they said that bronchitis, cough and sputum were not important, but they did only cross-sectional work. This is longitudinal data. And in females, of course, FEV1 is lower, but you see the same relationship. Which now moves me to blood eosinophils, which I'm going to talk about next. And really the interest in this came from a number of things, but this was one of the studies. This is the UK Isolde inhaled corticosteroid study, which was basically negative. But again, if the patients were divided into eosinophils less than 2% or more than 2%, there was an improvement in lung function decline on inhaled corticosteroids, while the patients on placebo deteriorated further. And this was statistically significant. Here you can see P0.001, while if they had low eosinophils, there was no statistical difference. So we certainly know in asthma, CS are significant. In fact, asthma was very carefully excluded. We were involved in this study and there was very careful screening. High eosinophil counts predict decline in lung function. This is more recent from Cancol. This is a very interesting Canadian longitudinal study. The red are the patients who had more than 300 eosinophils, and they were the patients with the faster decline. This is all other airways disease, including bronchiectasis. So high eosinophils in the blood predict lung function decline. Again, then there has been a lot of data on cutoffs. Can we predict exacerbations using eosinophils? The answer is no, it's not precise enough. And you can see here the cutoffs. This is exacerbation frequency at the bottom, and the cutoffs overlap enormous amount, but really the exacerbation frequency takes off at about 300, hence this figure for definite ICS use. So Gold embraced this at the last change and said that if the eosinophils are less than 100, and I'll show you the data, you don't need ICS, but consider if it's more than 100, and definitely if it's more than 300 eosinophils. So this is impact. This was the first big study where this was really tested. You'll remember this. This has LABA-LAMA against LABA-ICS against triple, and there was a benefit of triple. In fact, if you look here on the left, about 40% of patients had eosinophil counts above 200, which I think is right. And the top curve is the interesting one. The x-axis is increasing blood eosinophils, and on the right, you can see in green the LABA-LAMA. So the exacerbation rates on the LABA-LAMA increase with eosinophil counts, but that increase is stopped in the ICS arms as you go along to higher eosinophil levels. And the next curve is exacerbation. So the blue is in fact triple versus LABA-LAMA, and the red is LABA-ICS against LABA-LAMA, and you can see exactly the same patterns. But what you do see that around 100 here, there is no difference between the three groups. And that is because if your eosinophils are less than 100, you've got a very predominant neutrophilic inflammation. The other study I was involved is Ethos. This was different in that 2 doses of budesonide were tried, and very important as this had never been done before. Same data, both doses of budesonide, as you know, reduced exacerbation. So this is again triple against LABA-LAMA against LABA-ICS, very similar patients to impact. And again, the eosinophils come out. And here you can see if the eosinophils, we did less than 150, there is little effect, much greater effect in the higher eosinophil groups here on the right-hand side, whether you use the lower beclomethasone or the higher. So importantly, to prevent exacerbations, you don't need that much ICS. This is, in fact, again, shows you the same graph as for impact, exactly, and very consistent results, as you can see. So the pink is now the LABA, and actually it's impressive how similar these two are. And in fact, the effect is seen with both doses, as I said, of inhaled steroids. There was a significant effect on mortality. This was a secondary outcome, and the dark blue is the 320. The mortality difference was seen with a higher dose of ICS, and again, you see the eosinophil interaction. So this is now the higher dose of ICS, and you can see in pink the LABA, the chance of death increases with blood eosinophil count, but this is completely attenuated when you take the triple therapy here in the light blue. Of course, here the numbers become very small as you get to higher eosinophil levels. So these were all pre-specified analyses. So this is what Gold said. As I said, if strong support more than 300, consider 100 to 300, and against use if the eosinophil count is less than 100. But a very important point is, if you've got a patient with COPD and blood eosinophils, should you routinely add an ICS? And we looked at this in the ATS guidelines a few years ago. I have to say there's more data now, but at that point, we could not make for or against ICS as an additive therapy, except where there was a history of exacerbations. I must say, I think this question needs looking at in patients who are infrequent exacerbators, what happens to them. The problem is Ethos and Impact had exacerbators in their study. I just thought I'd remind you about Wisdom. Wisdom was an ICS withdrawal study, and we would not withdraw these patients. They were quite severe, but it shows an interesting interaction, which may be the answer to the past question. If you had one exacerbation per year, the eosinophils didn't seem to make any difference. While the patients who had two or more, if you had high eosinophil levels, you definitely needed the ICS, and you exacerbated with withdrawal. So this in a way suggests that in the infrequent exacerbators, there won't be so much issue. Just a few last slides. This is Sunset. These were patients who didn't need triple therapy, non-exacerbators. And in fact, one group was given triple in yellow, the other group had LABA, no difference over 6 months. But this was the interesting data, in that if the eosinophils were below 300, then it didn't make any difference whether you were LABA or triple, so you could have used a LABA. However, if you were above 300 eosinophils, you definitely need to continue with LABA-ICS. I would be careful with withdrawing ICS at the moment. We still, we can perhaps talk about this, but post-pandemic, I think there's still uncertainty about exacerbation levels. And we all looked at it. Again, the ERS said if the eosinophils are above 300, don't take them off. As I said, I would be very careful. Patients who have exacerbations, I would be very careful at the moment. Again, the eosinophil was seen with the anti-IL-5. This is mepolizumab. Again, the study was negative. If you break it down to the higher eosinophil counts, you can see that MEPO starts having an effect. My last slide is just to some exciting data about volatile organic compounds. This is data done with Seb Johnson's group in Imperial and my group. My group was the exacerbation cohort. They looked at cells and they went into experimental and came out that decane was a good candidate. And then they looked in our patients. And what we did here on the left, I'm sorry, this is a bit small. I put this in at the last minute yesterday. Stable exacerbations. We followed patients on very carefully. And the virus positive exacerbations had significantly increased decane in there. in their breathing, while bacteria pathogen negative didn't. Here you can see rise in decane with viral exacerbations, but not with bacterial. This, of course, needs confirmation, but I think it's exciting. So CRP may be useful if rapid testing available, but may be more useful in exacerbation recovery. This is future work. Blood eosinophils, predictors of ICS response in more severe patients, but not known if it holds in milder disease and really in earlier patients. And I think this is interesting. If we find younger COPD patients, what should we do? They may be useful in ICS withdrawal, but I've told you some caveats. I'm very positive about CT biomarkers and obviously ongoing early markers. So thank you very much indeed. I got over the technical problems and I'm delighted to speak to you today. Thank you for the invitation.
Okay. Thank you, Professor Wizia, for a nice presentation, informative, being on time. Because you are a little bit late, I'm going to allow for one question. If anybody has any question. Okay, thank you again, Professor Wizia, and hope to see you next year in the same conference.
And I'm sorry it's such a mess behind, but this is the spare room and the spare computer. I just realized what a mess there is behind here, but I wasn't expecting to use this room. So listen, thank you very much, everybody. I have been to your meeting before and I loved it, so maybe I can come next year.
Okay, thank you. Our next speaker is Professor Ashraf. He's well known, everybody knows. I don't need to introduce him. He's the president of the Emirates Thoracic Society. He's going to talk about a review of COPD in the last 2021 and this year. So we're going to review all the update about management and the assessment of COPD.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.